It's a pleasure to be here. And thank you for the introduction, and thank you for inviting me. The first time I do this webinar across the continent. It's remarkable how well the technology works. This occasion also reminds me of a British idiom, which we often use in the United States, that giving my talk to you is very much like bringing coal to Newcastle. As many of you know, some of the very best work in this area have been done in Europe by your colleagues and many others in the EU. So I certainly hope that we'll have a chance to share ideas and experiences in the future. My contact information here, that's my email, and feel free to email me anytime after my talk, and I'd just love to hear from you. I'll be talking on the use of immunoglobulins, primarily IVIG, intravenous immunoglobulin, which is obviously the predominant mode of administration that we use. I will briefly talk on subcutaneous use of immunoglobulin as well. As you must have guessed, my bias will be towards an evidence-based approach to the extent that the literature allows. And there won't be much time to talk about the many anecdotal successful use of the treatment in some of the less common and rarer neurological diseases. First of all, a little bit of history. The first therapeutic use of intravenous immunoglobulin came probably about 60 years ago, actually primarily intended as a replacement therapy in patients with B-cell disorder with very low gamma globulin level. Its use in autoimmune disease didn't come until much later, and somewhat fortuitously in a patient with ITP, who also at that time happened to have low immunoglobulin level. And the dosage that was chosen at that time, which have stuck since, is this 0.4 grams per kilogram per day for 5 days. In other words, about 2 grams per kilograms a day. And subsequent observations really suggested that the treatment has a profound beneficial effect on the autoimmune process, and that led to a explosion of the use of the treatment for really a remarkably wide range of both primary and secondary autoimmune diseases. Many of you probably know this. Perhaps the one thing to at least just remind the audience is that the product is a blood product collected from thousands of plasma donors, and the typical batch is representative of a pool from anywhere from 3,000 to as much as 60,000 donors. The pool IgG has compositions of the various subclasses very similar to normal plasma composition. And then different manufacturers have different processing, and primarily to ensure safety of the product. And the plasma center collection centers ought to have very vigorous screening criteria for donors, for infectious risk, and the pooled immunoglobulin then goes through fractionations and inactivations for various pathogens. About 15 or 20 years ago, there was, I think, there was a case of hepatitis B, for instance, transmitted with the use of GammaGuard that has since been traced to the manufacturing process, and the manufacturer has since replaced it with GammaGuard SD. In this case, the S stands for solvent, the D stands for detergent, which just reflects some of the commonly used inactivation procedure used to ensure safety of this blood product. And also different preparations have different kinds of stabilizers added to it, and that comes into of some importance when we get into the side effects profiles. Is that these stabilizers, the goal of it is primarily to prevent IgG aggregation, which is known to be one of the primary causes of many of the treatment side effects. I won't get into the specific immunology of immunoglobulin treatment. I have to admit, I'm a true novice in this. You probably wouldn't want to hear me talking about immunology. Suffice to say that the mechanisms of action are very poorly understood. We essentially have a product that is a collection of a very broad range of antibodies, and remarkably, it has been found to be effective in treating a staggering range of autoimmune diseases. Looking at the heterogeneity of the various disease types that respond to treatment, it is quite likely that IVIG itself probably act on these individual diseases with very different mechanisms. And so that's something to keep in mind of. The dosing is empirical, and for the most part, we don't really have much vigorous data on dosing. The most studies and most practitioners now use 2 grams per kilogram as the initial treatment, and that is usually distributed over 3 to 5 days. And there are even more variation in the subsequent treatments should the initial treatment works, and the subsequent treatment can be the full dose repeated every 4 weeks or so, or a somewhat reduced dose, and we often see ranges between 1 to 2 grams per kilogram. It is very costly, and I suspect it is very costly in Europe as well. This is the cost I tabulated about 5 years ago. This is just the drug cost itself, ranges from about $100 to $150 per grams. And if you think about the typical 70-kilogram patients, the drug cost alone would be about $12,000 to $22,000 or $23,000 in 2011, and the cost is probably at least 10% higher today. For such a costly, expensive treatment, we better have a firm foundation for its use. And fortunately, in IVIG, its use is supported by a reasonably deep set of scientific literature in at least most of the important neurological indications. even if its use is not formally recognized by regulatory agencies such as the U.S. Food and Drug Administration. Here are some of the neurological indications supported by randomized controlled trial. I will go over a few of them very shortly. By contrast, plasma exchange and other treatment frequently used in autoimmune diseases, there's much less literature support. And the likely difference has to do with the relative ease of use and availability of IVIG. And perhaps more importantly, many of these randomized controlled trials are driven by the interest, the financial interest of pharmaceutical companies, which sponsors many of the most critical clinical trials we have in the literature. All right, let's jump right into one of the indications, the Guillain-Barré syndrome. I presume I don't need to go into the clinical features of Guillain-Barré syndrome to this expert audience. And suffice to say that IVIG came into the scene around the time when plasmapheresis has already been accepted as a proven treatment for this disease. It becomes really untenable to do a IVIG versus placebo trial at that time. And the best data we have, unfortunately, comes from a equivalency trial looking at IVIG compared to plasma exchange rather than to placebo. Of course, equivalency trials have its own problem, primarily in terms of its sample size and whether the study is powered enough to detect small differences between the two treatments in question. And in this case, I think we have two very nice and rather large studies that indeed we feel are comfortable to be sufficiently powered to detect a meaningful difference of the two drugs. And the answer is there isn't one, or at least for the most part, there isn't one. The Netherlands study involved 150 patients using a primary outcome of the percent of patients that improved by at least one functional grade at 4 weeks. And in this trial, IVIG actually came out slightly ahead of plasmapheresis at the end of 4 weeks. While the larger trial in England showed essentially no difference between the two treatments. Subsequently, there have been attempts to see if we can do better. As you know, Guillain-Barré syndrome is a serious illness, and a common scenario most of us have experienced is that many patients we bring into the hospital may be intubated, maybe remaining on the ICU, and after the treatment, whether it's IVIG or plasma exchange, doesn't seem to improve all that much, and everyone would be asking if the treatment actually works, or if anything further needs to be done. And unfortunately, attempts to further improve the treatment haven't really produced much result so far. There were studies, as you noticed here, comparing IVIG with IVIG plus methylprednisolone, and in 233 patients, there was no difference. There was a smaller study comparing the IVIG for 3 days at 0.4 grams per kilogram versus the same dosage for 6 days. Again, no difference. So what do we do if the patient is not improving? All this reminded me of something I heard from Guy McCann many years ago. Guy McCann is a neurologist at Hopkins who spearheaded the initial plasmapheresis trial in Beyond the Way that was published in 1985. He told a story that at the end of the plasmapheresis trial, he took the straw polls of all the principal investigators in the multi-center trial. This is before results from the blinded data were known, and asked them if they think the treatment works. Just a reminder that the plasmapheresis trial was an unblinded study in which the investigator know which patient gets pheresis and which one doesn't. Apparently, the vote came out something like 17 of the 18 investigators voted no. They were expecting negative results. What that tells me is that it is really impossible for the clinician giving the treatment to know if the treatment works or not. We're dealing with a monophasic illness, and probably the treatment we gave patients doesn't really stop the disease totally, but hopefully influence the course of the disease in the subsequent days and weeks. Let's look at, for instance, one case series. This is a case series of 12 patients, all treated first with IVIG. And 4 of the 12 patients did not do all that well, at least at the end of at the completions of the IVIG. And the second course of IVIG was given, and the patients improved. So how do we interpret the data? I think this kind of data is impossible to interpret, especially for a monophasic illness like Guillain-Barré syndrome, in which the patients likely will improve anyway, regardless of what we do. And there is no way to know whether this second course of IVIG did anything. Yet, we are often asked, what else is there to do? And we really have only 3 choices, isn't it? We can do nothing, or we can switch to plasma exchange. I can't tell you how often I get asked that question. Or we can give more IVIG. And at least in my informal survey of my colleagues, the preference is all over the place, and probably with significant number of my neurology colleagues opting for each of these 3 options. Until we have better data, I think this is just a bit of a personal preference for the clinician. But I'll tell you what I do now in light of some interesting data, and I don't know how how it will pan out as we get more experience. So let's look at one study, again, coming out of Europe. This is a look at the immunoglobulin level, IgG level in the blood from the patients enrolled in the 2 randomized controlled trials in the Netherlands. You can see in this case a very nice increase in immunoglobulin level as we expect, peaking probably around 2 weeks and dropping down and back to baseline after a little bit over a month or so. And that coincides fairly well with the half-life of the immunoglobulin in the serum being around 3 weeks or so. What's particularly interesting is that when the authors stratified the data to look at outcome, let me just take you through that. The patients are stratified into 2 groups, into 4 groups, according to the IgG, the change in the IgG level after IVIG at 2 weeks. The group 1 has the lowest bump in the IgG level, while group 3 and 4 have the highest bump. Group 3 and 4 has the highest bump in the IgG level. And the outcome measure, these are Kaplan-Meier's curve, is the proportion of patients who walk unassisted. And it's quite clear that those who have a bigger bump in IgG level seems to have better clinical outcome. These are suggestive data, that the patients who perhaps doesn't metabolize the IgG as quickly are the ones that benefit the most from the treatment. So that led to my current, at least, thinking that if someone with the underweight who is not doing as well as we would like after treatment, if the treatment is IVIG, I probably will just give another course of IVIG. Totally non-evidence-based, or based on very flimsy evidence, but that's my leaning at this moment. It'll be interesting to hear what the rest of you think. So we have some unanswered questions in the underway. One is IVIG truly as good or same as plasma exchange? After all, we are primarily dealing with equivalency trial that is never large enough in terms of sample size. What's optimal IVIG dosage? There are various attempts to look at that without a whole lot of success. And we just touched on earlier about perhaps there's some rationale using a second IG course in the non-responder. And then we still are in search for any useful adjuncts to IVIG. Well, let's switch to a different disease, or at least a related disease, CIDP, chronic inflammatory demyelinating polyneuropathy. Here we actually have a very large data set in the CIDPs that are not associated with other systemic diseases. There are at least 4 randomized controlled trials. The only one that didn't show a clear benefit is the first one by Vermillion et al. This is unfortunately the earliest one that's the only negative study that enrolled a very small number of patients. I believe the number of patients is 28, and with a primary endpoint at 21 days, which probably is a little too early to measure outcome. While the other 3 trials are larger, and especially the latest trial, the one that many of you probably are really heavily heard about, the ICE study, clearly show a benefit of IVIG, and with outcome at 4 weeks, and in the ICE trial showing a much more long-lasting clinical benefits of immunoglobulin. We won't go into the individual studies in much detail, but let me just bring up a different question, and that is, when we're seeing a patient with CIDP, what should we use? We actually have some luxury here, because in CIDP we have several well-proven treatments. Steroids we know works, plasma exchange works, and of course the various immunosuppressants. There are plenty of anecdotal reports suggesting their benefit. Unfortunately, we don't have very good comparative data between these 3 mainstay of treatment: IVIG, steroid, and plasmapheresis. Let me just share with you one attempt to at least look at this issue. This is a retrospective study out of Italy, looking at a reasonable large number of patients, and these patients get one of the 3 treatments. As you can see, most of these patients get steroid or IVIG in roughly a similar proportion. And the response rate for responder, this is non-responder, the response rate is roughly the same, comparing the 2 treatments. And that response rate is very similar to most of us in our experience, is that not everyone responds to steroid or IVIG, but the majority do respond, and about 2/3 is probably what most of us have experienced. So for the non-responder, if they got switched to another treatment, and there's a good chance, for example, for the non-responder to steroids and who subsequently get IVIG, about half of them will respond to IVIG. And ditto for the IVIG non-responder, about 43% of them will respond to steroid. And taken all together, on aggregate, about 80 patients will respond to at least one of the three treatment and of these three treatment, plasmapheresis is obviously the least commonly used drug, both because of the cumbersome nature of the treatment and the lack of widespread availability in most institutions. So how should we choose? Well, there's no data to choose to help us to choose, and choosing, unfortunately, choosing one treatment over another probably depends on the comorbidity and the availability of the treatment, as well as the patient's preference. And the United States, at least, sadly, sometimes our choice of the choice is forced upon us by from interference from third-party insurance coverage. Is there any good predictor of someone might respond or not respond to IVIG? There's not much on this, and this is a recent study looking at this issue, coming with some predictors that is not very strong, at least in my view. But be that as it may, here they are. These patients with very dissimilar weakness between the arms and legs, patients with pain or have another autoimmune disease tend not to respond to IVIG. And the last one is the well-accepted one, and that is the CIDP associated with the IgM gammopathy don't respond to IVIG. How about a cousin to CIDP, multifocal motor neuropathy? Here, IVIG is also well established to be effective, and the best study comes from Angelica Hahn's study. This is a Baxter sponsored study. It's a crossover studies of 44 patients, and certainly validate what most clinicians already know, is that IVIG has remarkable efficacy in MMN. These patients improve remarkably. You hardly need any delicate outcome measures to show the improvement. And then the effects of the immunoglobulin wears off over 2 to 3 weeks, and then the patients get another dose, and they improve again. And the only problem here there is that we have a disease that is chronically dependent on immunoglobulin. Unlike some other autoimmune diseases, and for reasons that we don't totally understand, MMN primarily just responds to IVIG. Steroid doesn't work, plasmapheresis doesn't work, and most of the immunosuppressants, perhaps with the possible exceptions of cyclophosphamide, also doesn't seem to change the natural history of MMN. So we have a disease that is chronically dependent on IVIG. And the neuromuscular specialists among us probably are familiar with the situations of each of us having a handful of patients who have been getting IVIG treatments for decades, and we just don't have any other way to get them out of the dependence the dependency on IVIG. Along the line of the possibility that the IgG level might govern, might predict responsiveness, there is another piece of data in MMN. In this case, again, the authors look at the immunoglobulin level after IVIG infusions. The green bars are the actual total IgG level after infusion. Day 1 is here. So there's a nice bump of IgG that lasts about 3 weeks. And then the blue bars, the darker blue and the lighter blue bars, are the change in IgG level. And in this case, those who responded well seems to have a higher level than those who did not respond as well. Again, suggesting that perhaps we need different dosing for patients if the IgG level is a major determinant on the efficacy of the treatment. So we have some unmet challenges in MMN that I talked about already. There's really no alternative to IVIG, and there's this problem with chronic dependency on IVIG. And many of these patients have really a lot of problem with venous access, and that gets to the use of sub-Q immunoglobulin that I'll get into very shortly. But before we get that, let's just quickly touch on myasthenia gravis. Obviously a very important disease. There is one randomized controlled trial by Simon et al. Not a large group of patients, but at least enough to show a statistically significant benefit in those patients with moderate to severe myasthenia gravis. Subsequently, we have a couple of other equivalency trials comparing IVIG with positive exchange, at least within the capability of the study, especially with the Roninger study that shows that enroll only 12 patients. The study did not show any difference. So, roughly speaking, IVIG and plasma exchange are probably equivalent. What we don't know, however, is whether IVIG works for chronic management of myasthenia gravis. Anecdotally, many of us think that it probably have a role in selected patients, but there is really no good controlled studies on this. We have very little data besides anecdotes on seronegative or MuSK-positive myasthenia gravis. And then many old-timers in the field often still question whether IVIG is truly equivalent to plasmapheresis. And many clinicians still think that plasmapheresis probably is a more effective treatment, even though the equivalency trial didn't show any proof to that concept. Let's go quickly on some other things that I'll just briefly mention. There are several indications that that the data seems to be quite overwhelmingly negative. Neuropathy associated with IgM, IVIG doesn't seem to work. Ditto, IVIG doesn't seem to work in inclusion body myositis and Alzheimer's disease. In a couple of indications, I think the data is still out. The verdict is still out. There are at least half a dozen randomized controlled trials in multiple sclerosis. With 2 showing efficacy and 4 showing no efficacy, and I don't know how widespread is its use in MS. Certainly in these days, with so many alternative treatments, I would imagine that IVIG must have fallen out of favor if used at all. A rather controversial syndrome, mainly because it's hard to define, is post-polio syndrome. There are 2 randomized controlled trials that show mixed and equivocal results. And perhaps most interestingly to some of us is that there are a wide range of neurological diseases that appear to respond to IVIG. These are, for the most part, rare syndromes in which randomized controlled trials are probably impossible to do. But anecdotally, the treatment seems to work. And we're limited, in other words, primarily to class 3 or class 4 data. Autoimmune encephalitis, that includes, for example, the NMDA antibody-associated encephalitis, various paraneoplastic syndromes, Lambert-Eaton syndrome, some of the autoimmune sensory neuropathies, and here is complex regional pain syndrome or reflex sympathetic dystrophy. There's some suggestion that there might be an inflammatory basis and perhaps some role for IVIG. We won't have time to get into any of these. This is really just posted here for your information. Let's get into a little bit about, talk a little bit about side effects. In this case, we need to understand that not all immunoglobulin preparations are equal, at least when it comes to side effects. For the intravenous preparations, they usually come in 5% or 10%. So it's an important issue because in the neurological diseases, we usually use a lot of immunoglobulins. And even if we use a 10% preparation, we sometimes end up giving patients a liter of fluid with each infusion. So that might be relevant or might be problematic for certain patients. Ditto for the sodium content and as well as the osmolarity content. Those needs to be factored into our thinking in administrations of these of immunoglobulin. The 2 other things should be also play an important role. Some of the preparations are lyophilized or freeze-dried and has to be reconstituted. And the lyophilized preparations appear to be associated with a higher rate of side effects. And another important issue is the stabilizers that the manufacturer use, and some of them are responsible for side effects. For instance, sucrose is is known to be associated with renal failure in patients. To keep the immunoglobulin stable, all the preparations have an acidic pH, and the pH range from 4, as low as 4 to 6.8. Even though they are fairly well buffered, this might be an issue in terms of irritating the veins, and that particularly becomes an issue in the pediatric populations when they have small veins. However, there is no proven difference in efficacy between the different brands. So what about side effects? The most published studies note side effects in as much as 30 to 40% of all patients getting IVIG. But fortunately, most of the side effects are the infusion side effects, and relatively benign, self-limiting, and goes away once infusion is stopped, or can be at least controlled by changing the rate of the infusion. Other fairly common side effects are rash and aseptic meningitis. So for the most part, IVIG is very well tolerated despite the high percentage of patients who will report some side effects. And for the most part, IVIG is safe, except for rare instances of these more serious side effects. I once lost a patient, a relatively young guy, who died of a pulmonary embolus from a deep vein thrombosis, presumably related to the immunoglobulin treatment. Hemolytic anemia is occasionally encountered. Renal failure, we mentioned earlier, most of them is associated with sucrose, and that if that becomes an issue, that can be managed with choosing the right preparation and watching the osmolality and the volumes of the infusion. And there are rare instances of anaphylaxis and TRALI, which I have never seen. TRALI stands for transfusion-related acute lung injury, a frightening respiratory disease that sometimes needs intensive support for at least a period of time. Let's not forget IVIG also may change some laboratory markers, obviously raise the sedimentation rate. So ESR after IVIG is fairly meaningless. Some patients might have mild hyponatremia, and it might give false positive serologies, certainly in some of the more commonly more prevalent infections in the population. I want to at least quickly close with a comment about subcutaneous IG. That is certainly an emerging trend. Obviously, the advantage is that an IV is not needed. And for the right patient, this can even be self-administered and therefore save a lot of expenses. It does, however, require more frequent administration. I'll show you an example of that in just 1 minute. And the pharmacokinetics is quite different. When you look at the serum level of IgG, you get a much lower peak, as much as 40% lower than you will get with an IV infusion, not surprisingly. However, because of the more frequent administrations that is needed, you get a higher trough. And sometimes you actually end up with a net increase in total amount of immunoglobulin through the treatment period. And because of the less peaks and valleys in the immunoglobulin level, there is less infusion side effects. So this is an example of a patient with MMN that I recently dealt with, who has required 170 grams monthly of IVIG for many, many years, and basically he used up his gains. So we went through the calculations of subcutaneous immunoglobulin. In this acute concentration preparations, the highest concentration we can get these days is a 20% preparation, and that gets to a substantial amount of fluid that needs to be infused every month. And for most people, the maximum we can deliver is about 60 ml per day, and this is usually delivered through 3 or 4 needles over about a little over an hour. So the calculations would then dictate roughly every other day of infusion using the subQ method. In this one particular case, my patients opted for a port instead of the subcutaneous IG. But it's partly because he doesn't want to have a needle stuck in him every other day. But for other people, especially people who have perhaps a lesser requirement of immunoglobulin, subcutaneous IG is certainly a very viable option. So let me just wrap up. What I have talked about is that immunoglobulin is actually quite ubiquitous and safe, albeit expensive, in the treatment of neurological diseases. It has very well-established efficacy in many of the diseases that we deal with. There's some emerging evidence to suggest that IgG level might correlate with efficacy, and perhaps we need to monitor that more vigorously, and hopefully we'll accumulate more clinical experience with interpretations of these IgG level, and be smarter in the treatment of these diseases. There are other emerging trends, the use of subcutaneous administrations that I mentioned, and there are certainly ongoing efforts to replace IVIG, which is both expensive and relatively unavailable. There is a relative shortage of immunoglobulin, partly because of the expanding use of this agent in various diseases. So there are attempts to use recombinant preparations, and then hopefully in the next decade or so, we'll see some of these new efforts coming into clinical use. Thank you very much, and thank you for your attention.
Thank you very much. Thank you very much, Professor So, for this excellent and comprehensive overview. We have about 5 minutes for some questions. We will start with our center to give time to the other centers to prepare for the questions. The next center will be Geneva. Now we start with Aarau. Do we have Matthias, please?
Yeah. This is Matthias Tröger from Aarau. Could you comment on the skin side effects, and how do you manage them when they
So, we see that not infrequently, and I usually enlist our dermatologist and have liberal use of topical steroids and other topical measures. And well, sometimes changing the preparation might help, but most of the time it doesn't. The hypersensitivity is probably to the immunoglobulin itself. So we ended up having to make that decision as to whether the patients can tolerate this. Most of the skin reactions are not too severe, and I certainly have a couple of patients who have continue to go through treatment despite regularly getting a rash for 2 or 3 weeks. That is managed with topical treatments.
Thank you very much. Now we go to Geneva. The next center will be Lausanne. Do we have questions from Geneva?
Yes. Hi, Roxana from Geneva. Do you hear me?
Not well. Can you speak louder?
Hi, do you hear me now?
Very well, thank you.
Yes. So I have a question about CIDP. A patient who is on chronic IGIV every 4 to 5 weeks. We have seen that in some cases there is a worsening after a certain time, after 1-2 years, and the association of methylprednisolone improves the situation. Have you some experience in this association of IGIV and methylprednisolone?
You mean using them together?
Together, yeah.
Yes. 2 comments. First of all, certainly, anecdotally, we see patients who did well with one treatment and with time seems to lose its responsiveness to the treatment. And IVIG would be one example, is that someone might be responding well and then stop responding. So that's not uncommon. And then we get into other modalities, and it's not uncommon for us, especially when patients is doing poorly, to use multiple modalities at the same time. Sadly to say, sometimes what we use depends on how desperate we are in getting the patients better. Using immunoglobulin with prednisone is very common in the more refractory cases. We have also used other cytotoxic drugs. We're certainly not afraid of using cyclophosphamide or the lesser immunosuppressive such as azathioprine.
Okay, thank you.